Okay, what's up guys? So my name is Alex Greater and I am a registered biokineticist with the Health Professional Council of South Africa. I wanted to create this channel as a teaching and informative channel to help people better understand exercise rehabilitation, resistance training, endurance training, and a combination of both. Now I'm going to try my best in this channel to keep everything factual and research based. But I do think it is very important for you to do your own research, gather your own information, and make your decisions based on calculated information that you received, as well as research back that you did yourself. So for this video, I am going to speak about orthopedic rehabilitation and how to effectively quantify your data to see a linear progression in your orthopedic patients to ensure that they have effective rehab and go pain-free and prevent any future injuries or re-tears of specific injuries that happened before. So in this video, we're going to be speaking about two of the major components that we use as quantifiable data to ensure effective rehab. So the first thing that we're going to speak about is going to be range of motion. So when it comes to range of motion, because the knee joint is specifically a hinge joint, which looks like this, there are only two major movements that can happen in the knee joint. So if this is your hip, your knee and your ankle, this will be your femur, and this is your tibia and fibula. And then we have a flexed knee joint, which will look like this, again with your femur and your tibia and fibula. So we have knee extension and we have knee flexion, which are the two primary and basic movements that happen in the knee joint in itself. So these are the two main movements that we look at when it comes to range of motion. However, because there are two joint muscles that present in the knee joint, there are specific movements in the hip joint that we can take a look at as well. So what does a two joint muscle mean? It means a muscle that spans across two specific joints, just like said in the word. So one of the primary muscles that is a two joint muscle is going to be your rectus femoris muscle. So it spans from your hip joint across to your knee joint. And what this means is, if your hip joint moves, then it means the rectus femoris muscle will move as well. So if this is your starting point of where your hip joint is, and your hip joint goes from this position to there, and your knee joint is there, it means that because the rectus femoris muscle is on both the hip and knee, because the hip joint is moved upwards, the rectus femoris muscle will pull the knee joint upwards as well into this position, causing hip flexion to bend the knee upwards. And why this is important is because when we look at range of motion, and we're going to look at the knee joint specifically, then taking a look at the range of motion, we have to take into account that some of the movements in the hip will affect the knee's range of motion as well. So the four basic movements that I would suggest is very good when it comes to knee rehabilitation and quantifiable data for range of motion would be, in essence, your knee flexion, your knee extension, your hip flexion. And now your hip flexion is broken into two components. Because we have a two joint hip, your hip flexion can either be done with your knee straight or with your knee bent. Now with your knee straight, we call that test a straight leg raise. And with your knee bent, we call it hip flexion, but your knee is flexed. Now, even though a straight leg raise assesses your flexibility of your hamstrings, which is also important when it comes to the knee joint because it has to do with knee flexion and how effective your hamstrings are. And even though your hip flexion assesses the flexibility of your glute max muscle, Both of these movements have involvement in the knee. That is why we use them in range of motion testing for the knee as well. So we take a look at these 4 basic components, and then there are specific norms for each one. So when it comes to knee flexion, we're looking at anything above 135. And because your patient is injured, we're going to say they present with 110 degrees of knee flexion. For knee extension, it's between 0 to 10 or 0 to 15. But in my opinion, it would be better for you to get as close to that 0 degree as possible, just because it is called terminal knee extension and it is something that we use on a daily basis. You want your leg to be able to be fully straight and have no bend in it. For hip flexion, we are looking at between 110 degrees to 120 degrees with your knee flexed. And for straight leg raise, there are some differing opinions based on research. Some research indicates 70 to 80, others 80 to 90. But in my opinion, again, getting as close to that 90 degree as possible is going to be the best outcome for your patient. So knee flexion, your patient has 110. In knee extension, your patient will have 5 degrees. Now, in my opinion, again, opinion, not fact, if your patient presents with 5 degrees and the knee is bent, 5 degrees in a bent position, I would term that as a negative 5 degrees because they have not reached 0. Once they go above 0 and even more than that into hyperextension per se, then it falls in that 0 to 15 category. Okay, whether you put it as a minus or a plus, that is up to you, as long as you stay consistent in the measurement that you use and you are aware of what you quantified it as. For hip flexion, your patient will present at 100 degrees, and for straight leg raise, your patient will present at 60 degrees. Now we have 4 basic movements and 4 numbers, quantifiable data, that your patient presented as in week 1 of their rehabilitation with you. Now, my suggestion from this is what you should do, or what I would suggest you do, is you're going to take those 4 numbers and you're going to plot them on a graph. And this is going to help you to see linear progression much better. So you take a graph and you're going to put all your range of motion on the x-axis and you're going to put degrees on the y-axis. So we have your knee flexion, your knee extension, your hip flexion, and your straight leg raise. And then on this axis we have degrees, and the top will be 180 degrees. So you plot your numbers as your patient presented to you. For knee flexion, your patient presented with 110 degrees. For knee extension, if your patient was in the negative, they would be there. If you turn to put them in a positive, then you can do that with them. And for hip flexion, your patient presented at 100 degrees, which will be there, and your straight leg raise was up to 60 degrees. So that is where your patient is currently at. Then I would suggest you put the norms on the graph as well. So for knee flexion, we want your patient to be at 135 degrees. So your norm would be there. For knee extension, either way, if it's 15 and you put your patient on the negative on this side, then your norm would be there. If you put it as a positive, then it's still there. In my opinion, as long as they get to that 0 portion, then knee extension and terminal knee extension is met. For now, I'm going to put them in the negative just so that I know that their knee is not straight and their knee is still in a flexed position, and we want them to get there. For hip flexion, they are at 100 degrees and you want them at 120 degrees. And for straight leg raise, you want them at 90 degrees. Now you have numbers and you have norms. So if we have our knee flexion at 110 and the norm is 135, now you know you need to make up 25 degrees. For knee extension, they're at -5. I want them at 0, so I know I want them to get at least a 5 degree increase. For hip flexion, they were at 100. We want them at 120, so we want 20 degrees as an increase. and for straight leg raise they were at 60, and you want them at 90, so you want a 30-degree increase. Okay, so you have your baseline. This is where your patient is currently at. This is where you want your patient to be, and these numbers are what you want them to achieve in whatever timeline it may be. If it's 12 weeks, if it's 18, if it's 24, those are the numbers you want them to get better by. So if you run your rehab and we reassess our patients at week 6, then you use either a new graph or you use the same graph and you plot their progress from their reassessment. Okay, so if your patient went up in knee flexion from 110 to 120, now we know they are at 120 and there's 15 degrees left. If they went up in knee extension and they went down to -3, so they went down to -3, now there's only a 2% deficit, a 2-degree deficit. If their hip flexion went up to 110, now there's only a 10-degree, and if their straight leg raise went up to 70, now there's only a 20-degree difference, and they were at 30. Now you can use all of those numbers. These are the new numbers, 2, 10, and 20. So if we take a look at their knee flexion, they went down from 25-degree deficit to 15-degree deficit, and from knee extension they went down from 5 degrees to 2 degrees, and I'm going to use hip flexion as a percentage marker. Because they went down from 20 degrees to 10 degrees, you can see there is at least a 50% increase in their range of motion in 6 weeks. Now, this is a good indication for you to see if your patient is going to finish their 12-week rehab program. If they have 50% increase in 6 weeks, effectively it means that by 12 weeks, they should be back to full range of motion. And because you have kept track of their quantifiable and objective data, you can see that there is a linear progression happening in terms of their range of motion. So this is the first major factor that we look at. The second one that we're going to look at is going to be your muscle strength. Okay, so muscle strength. We are again going to look at knee flexion, knee extension, and you should know that muscle strength and flexibility are intertwined. Muscle strength cannot occur without range of motion. So these movements do often overlap. For muscle strength, we're only going to look at the two primary components, which is going to be your knee flexion and your knee extension, just for time's sake. So when it comes to knee extension, the 4 basic muscles that we look at is going to be vastus lateralis, vastus intermedius, vastus medialis, and rectus femoris. There are 4 muscles, and these are the 4 muscles that make up your quadriceps, hence why they are called quad, meaning 4. Then when it comes to knee flexion, we're going to look at biceps femoris, semitendinosus, and semimembranosus, and these muscles will make up your hamstring group. Okay, so for muscle strength, it is very similar in terms of the quantifiableness and the way that we look at it. So in the old days, they used to use manual muscle strength as a method of testing, where you as a practitioner or as a healthcare professional will apply resistance with your hand and subjectively measure if your patient's muscle strength is between level 1 or a level 5. However, with the advancement of technology, we now have things such as the isokinetic machines, as well as little devices that we can put on our hands, which measure force output, which are called handheld dynamometers. Now, with these things, you can measure force in pounds, kilograms, or newtons, depending on which country you fall in, and they will give you an indication on which muscle group and how much, not which muscle group, but how much force each muscle group presents with. So if our quads are giving us an output of 20 kgs and our hamstrings are giving us an output of 10 kgs, then we can use that measurement again and we can plot them against the graph. So the only thing with muscle strength and handheld dynamometers is the research has been very limited. So in my opinion, if you do want to base these off of normative values, there's a research paper called the 1000 Norms Project, and that's an R, 1000 Norms Project, and currently it was a very good sample. The previous studies are very outdated. Until new research presents itself, you will have to look at trends in muscle strength, but you can also compare them to this research study if you so wish. So using these measurements, we plot them against the graph as well, and it's going to be a very similar thing, so I'll run through it quickly. So you're going to have quads and hamstrings, and you're going to have kgs, and that will be 100 kgs. Your quads will be at 20 and your hamstrings will be at 10. This will be week 1. And then in week 6, if your quads moved up to 40 and your hamstrings moved up to 20, that's week 6. Then again, you can see what percentage increase there was between week 1 and week 6, and same for quads and same for hamstrings. Now, does increase in muscle strength necessarily mean less pain? And the answer is not essentially. You still have to look at patient feedback and what they tell you if their pain levels have subsided. However, increase in muscle strength does mean more joint stability and also means prevention of future injuries, because the muscles are now taking the load off of certain ligaments that were previously injured. The stronger your muscles are, the more stability in the knee joint, and the less the possibility of the knee presenting itself outside of anatomical ranges where it shouldn't be. So in essence, if your vastus medialis strength has increased significantly, it does mean the collapsing of the knee will not occur as much as it did before, which could be a contributing factor to something like an ACL tear. So muscle strength and flexibility, very similar in essence. You do initial assessment, progression up to week 6, see if there is a linear trend specifically in that knee joint, quads and hamstrings. Now, I know there are accessory muscles that play a role. I'm not saying only assess these 2 muscles, but what I'm saying is you use the same method that you did for these muscles for those accessory muscles to ensure there is a linear upwards trend in muscle strength. Okay, then there are 2 other portions of quantifiable data that we can look at as well that can assist you in making sure your patient is effectively rehabbed and making sure that they do not injure themselves again. The first one that we're going to speak about is going to be your dominant versus non-dominant. So we're going to take a look at it in perspective of range of motion first. So you're going to have your right leg and your left leg. Remember, you have to measure both. So if we do range of motion for your knee flexors, and we're going to say that the right leg was injured because predominantly people injure their dominant legs. Because of unequal weight distribution, people usually injure the leg that they end up using more because of reasons for overuse, and overuse could lead to traumatic injuries. So if we take a look at knee flexion and your right leg presents with 110 degrees, but your left leg presents with 140 degrees, that means there is a 30-degree deficit between the 2. Now, why is this a bad thing? If your patient is going to do a hamstring curl, where this is now their femur and their knee and their ankle, and this is going that way and that way. Your right leg is mobile and effective in range of motion up until 110 degrees, which we are going to say is there. More or less looks like 110 degrees too. That is 110 degrees, but the movement is not yet finished. So you go further up until, we'll say, 130 degrees. Your right leg is not predominantly contracting muscles further than 110 degrees. So in that window span, your left leg is predominantly doing the work. It is taking the contractile force, it is doing more of the strength. And why is this a bad thing? Because your right leg is injured and you want to increase the strength of your right leg in full range of motion, but your left leg is taking the predominant load in the area that your knee joint is most susceptible to injury. So instead of doing bilateral movements, we have to highlight the importance of unilateral movements and increase of range of motion so that we can do more muscle strength in the full range of motion. So if you're going to do a lying or seated hamstring curl or a Romanian deadlift, I know bilateral movements are easy to prescribe, but you have to ensure that you do unilateral movement. And once you expose the patient to unilateral movement, and just to clarify, unilateral meaning one leg at a time, bilateral meaning both at the same time. If you're going to do unilateral movements and you do a Romanian deadlift, do a single leg Romanian deadlift, that is going to expose to you the patient's capability as well. Because on the left leg, he might be able to do a Romanian deadlift with 20 kilos, but on the right leg, he can only do with 10 kilos. Now, you do not want that big of a difference, so you prescribe 10 kilos for both until the right leg progresses and the left leg can then linearly progress with it. If you're going to keep overloading the left leg, you're going to increase that gap, and this right leg strength will never get to the place where the left leg is. Now, where do you want these numbers to fall? Obviously, you want them to fall in the norm, which is 135, but also, and this is more applicable to muscle strength, but you want them within a 5% deficit so that they are very, very close when it comes to mobility and full range of motion. Okay. Then the same thing applies when it comes to muscle strength. When we look at muscle strength, and we have your left, that's not an L, we have your left and your right, and your right leg is injured, so it can do 10 kilos, and your left leg can do 20 kilos. It's the same thing. If you're going to do bilateral movements and we have a 30 kilo load, we'll say you have RDL, a Romanian deadlift, and the barbell is now 30 kilos and you are using both legs, there is an unequal split being distributed towards the right leg than towards the left leg than in terms of the right leg. And this is also why in gym settings you'll see people with unequal bar paths looking like this. It's because one force is pulling it up more than the other. In this case, because the left is stronger, it's going to look like this. Now, it might not present as severe as this, but what you will see is a wobble. So even in a deadlift, the deadlift is the most common. When you look at bar paths, you most commonly want to see linear up and down straight line. But what people do is this happens and they pull unequal because of the deficit between left and right and that unilateral deficit. So you want to get this as close as possible. So again, you want a 5% deficit between the two, and optimally you want to get them as close to each other as possible to ensure that, again, bilateral movements, you're getting equal contractile force through both of the legs. Okay. Then the last thing that we're going to look at is going to be your agonist and antagonist. So in your agonist to antagonist, your agonist means the muscle that is working or the muscle that is shortening during contraction. Your antagonist is conversely going to mean the muscle that is lengthening during contraction. So if we're going to take a look at the quads and the hamstrings, or knee flexion, knee extension, if your hamstring muscles are shortening, that means that they will be the agonist group. If your quadriceps are lengthening, it means that your quadriceps will be the antagonist group. Now, we can use quantifiable data for this as well, and I'm going to explain why this is important in just a second. So if we're going to say that your hamstrings are 10 and your quads are 20 kgs, to quantify this, we say your, we're going to do, let's do quads versus hamstrings. So we'll say it's a leg extension, and your quadriceps are going to be your agonist, and your hamstrings are going to be your antagonist, just to make these easier. You're going to put agonist over antagonist, and you're going to times it by 100. So you're going to put, no, I did it the wrong way now. You essentially want a small number at the top. So we'll do what we did initially, which is fine. Antagonist over agonist. So we're going to say 10 over 20 times 100, which is going to give you 50%. Okay, so it means that your hamstrings have 50% of the force output that your quadriceps have. Sorry for the confusion, but you put the smaller number at the top, divided by the larger number, you times it by 100, that will give you your agonist to antagonist ratio. So it's in this space, it's going to be 50%. Your hamstrings can do 50% of what your quadriceps can do, your quads can do 20, your hamstrings can do 10. Now we have normative data for this as well. For hamstring versus quads, what we want is the quads to be 60%, and we want the hamstrings to be 40%. So in this case, it either means that the hamstrings are too strong, or the quads are too weak. Because these numbers are so low, I would say it's both. So you would want to increase both linearly, but you want to increase the quadriceps more than you do the hamstrings. Now, the reason we have such a big gap between the two, the 60-40% split, is your quadriceps are 4 muscles and your hamstrings are 3, as well as the fact that your quadriceps have a larger surface area than your hamstring muscles. They would present with more contractile force. Now, the reason for this is in biomechanics and daily posture and ergonomics and the way we conduct ourselves, your quadriceps take a higher load than your hamstrings do. In the way that we walk and the way that we do things every day, your quadriceps need to be stronger for certain functional movements throughout the day. And this presents across the body in terms of, if you have your biceps comparative to your triceps are 3, your biceps are 2. Again, you have an agonist-antagonist ratio, and biomechanically, some movements need to be stronger than other movements. Now, the reason we look at this in terms of rehabilitation and prevention of injury is if you present with a 50% like we do here, it does mean that because his quadriceps are not as strong as they should be, he runs a risk of injuring his quadriceps or having a knee joint injury because of that lack of muscle strength, which is going to prove to have knee instability. Especially if you look in the niches of if his vastus medialis, which is included in his quadriceps, lacks in strength, then his knee is prone to collapse inwards, which will cause an injury to certain ligaments or tendons. So that's what we want to stray away from. We want to have both agonist-antagonist ratio within the normal ranges, along with your dominant versus non-dominant being as minimally decreased as possible. Okay, so those are the 3 major components when it comes to assessing quantifiable data to see linear progression in your patient. So what we looked at was, we looked at the range of motion, muscle strength, your values specifically in your graph and your trend. So what does your trend say in terms of objective measurement? Is your patient making improvements in a 6-week, 4-week, 8-week, 12-week period? Can you quantify it? Can you see that there is actually a progression, and that your patient's end date or his clearance date where he can be released and go back to return to sport does he meet that criteria where within the 12 or 24 week period he will finish his entire exercise program, his exercise rehabilitation with you. The second thing that we looked at was the right leg versus left leg, the unilateral dominant versus non-dominant comparison. Do they fall within a 5% deficit? And then the final thing that we looked at was your agonist to antagonist ratio, and is that within the researched norm for that specific agonist to antagonist ratio group. Just for reference, not all muscle groups present with 40-60. They are all quantified in their own way, so you can do your own research to find out which specific agonist to antagonist ratios apply to which muscle groups. So these are the three things that you can use data for. Quantifiable data, see linear progression, see a decrease in the patient's, see a decrease in what they need to catch up on, see an increase in strength and range of motion. And then the final thing, obviously, again, you have to have subjective feedback from your patient on pain levels to see that along with their progression in data, that physically that their pain is starting to subside and they are feeling stronger and better. Okay, so that was my first video on effective rehab when it comes to orthopedic rehabilitation, specifically of the knee joint. Thank you very much, and I hope you have a blessed day.